Thanks to the Lab Medicine Ground One Committee for inviting me to present the UW China Health Initiative. This initiative includes research collaborations with China as well as related professional training between many members at the UW, Hutch, as well as China. The initiative was launched in 2007 when the university leadership recognized the discovery and solution for some of those diseases that are difficult to cure or vaccine prevent is beyond the capacity of any one institute or one country. So we should coordinate collaborations in priority area of mutual concern and the benefits. And we should leverage existing or identify actually new, particularly in the human and the financial resource. We would like to explore the new organization models or business structures that will ensure financial opportunity in those rapidly changing global research and development environment. This is what the UW president, Mark Ehrman, said in 2006. In my mind, no task seems more crucial right now than to expand our thinking about China, to try and to open our perspective beyond the duality of mercantile opportunity and the competitive threat. So this is a time that perhaps more than ever demand balance and reflects. So when we review the worlds today and when we review those we have achieved from this program that I will present soon, you can clearly see this is it's great. Actually, you have this president with a global view and in advance and allow us to be in good position today. So the UW Hutch China initiative is really the timely convergence of need and interesting from both sides. UW Hutch and actually now other universities in the United States also join us to seek for the access to the new resource globally, basically, and also some of those talented, human resource students and postdocs. Well, in China, they're actually looking for at that time, actually they're looking for, benefit from those world-leading research institute and collaboration in those areas they are interested in. And also, China has a unique opportunity compared to other developing countries. They can provide the state-of-the-art, infrastructures or equipment and ground opportunities. This right now is important. And also because large population, they provide the human or biological resource that typically, or in most cases, not available here in the United States. So there was an opportunity for UW and Hutch to leverage those competitive advantage over there by forming alliance with our regions, nationals, or even right now we are global partners. The UW China Health receive broad-based support from both United States and China. Specifically, our university, the President Emmer, who actually initiated this idea and led us to begin the program. And Provost Phyllis Weiss actually has been provide leadership and personally spent a lot of time with us and develop the program before we this is a handover to School of Medicine under the Dean Paul Ramsey. For the Hutchinson Cancer Research Center, President Dr. Lee Hadwell has been very supportive to his faculty, and now actually he's beginning to work with us with his personal program that I will describe later. China also provides very strong support. One of those significant is really the high-level Chinese delegation that is headed by State Councilor Madden Liu, who actually is in charge of entire China education and research programs. So those minister that actually was part of the group, Mr. Zhu of Minister of the Education, Mr. Li, the Deputy Minister of the Science and Technology, who is actually the founder in China, as well as Zhou Wenzhong, who is the Chinese embassy in China, in the United States. Those people actually report to him, to her, Madam Liu. And also in the last few years, more than 20 or those China University president and vice president visit us for potential collaborations. The overall goal of this China Health Initiative is really try to create a research and development environment in China for our faculty members as well as students to do the collaborations in developing new programs, basically in basic or clinical or translational research, as well as the education training in the area of infectious disease, non-communicable disease, and those that have impact China, our region, Pacific Northwest, and as well as the world. So specifically, one of the major goals is really to create a network of joint institute that allow our peoples to work over there with and get the first hands of those experiments as well as the data access. This is probably most important that we have done, which actually allow us to be better to achieve the following goal that include that this will provide us new binational grant opportunities for research collaborations that will benefit and bring the sustainage to our all partners, and reducing the barrier to those comprehensive substantial collaboration, which happens many times by link our growing faculty member work over there. This is true. When we start the program, we recognize there are a lot of ongoing UW faculty program over there. We never recognize. You can't imagine how many of those people are. But when we start program, we constantly was asking by these faculty how you guys can help us again. So we try to do that by link out those growing community, faculty community in China, with the center service and resource. And with that, we hope to build a strong relationship between our faculty member and help them to with China. And finally, and further on, we would like to extend that to be in the Pacific Northwest or even U.S.-China alliance. This is something that we are developing right now. So this is the slide shows the overview of current view of UW China Health Initiative that has two major arms. One is research. I have to use this point. One is the research and the development. One is capacity building. And under the research and the development, the phase 1 program actually is focused on infectious disease. Those major, including the HIV, TB, and HBV dose, and also emerging infectious disease like flu. So I will provide more about this later because this is related to my own program as well. This phase 1 program is for really non-communicable disease. We actually began this program, developing this program, especially for cancer, including GI cancer, liver cancer, breast cancer. And I will talk a little bit about this, the program that we have been developing. The capacity building program, it's at this point is more focused on professional training related to those research programs, and those list over there are current that we are thinking, and some actually ongoing. One of those related to lab medicine and global health both is really the medical laboratory training program. I think there's a chance that we can implement, and China is definitely interested in this program. One of the unique of this China initiative is really the infrastructure to join the institute that we create over there. We basically have already created one institute that I will describe a little more later at the Guangzhou south of China, Hutchinson University. And we also are developing an agreement and with China CDC in Beijing, as well as Peking University in Beijing, UN Hospital in Beijing, but also Fudan in Shanghai. So essentially Beijing, Shanghai, Guangzhou are the three largest cities in China, and we are covering that. And those programs listed on here works. And basically independence but collaborate. Okay, so those programs will be conduct and different area in those joint institute. So where we are right now in those infrastructure operation, UW opened an office in Beijing in 2007. And the first institute established that in Guangzhou is the Institute for Translational Medicine, and we are also in the development, basically, in the agreement development phase with China CDC and others in China. So why we do that? It's really the joint institute. Basically, has been created in order to meet the need of facilitate those very rapidly growing and UW community, faculty community collaboration in China. We hope this joint institute will serve as the center labs at headquarters for the research and the education that will be needed for future of the collaboration between UW, Hutchinson, and now actually extended to even other universities in the United States. And that essentially created a lot more grand opportunity for us. So this is actually the summary of the first institute, what we call the Hutchinson University, which is actually a top 10 university, but it's number one in the south of China in Guangzhou. So it's the SYSU, UW Institute for Translational Medicine, or we call ITM. This is an institute that actually created with all money from China. We don't actually put any money over there. It's basically China raised the money to build the institute, buy the equipment. And now the collaboration between our people and partners in China, including Hutchinson University as well as other part in Beijing, are ongoing. But that doesn't mean that's all the program we are going to do. Basically, we are looking for to host the new programs. One of those that I actually had the chance to talk to a professor from global health, and there might be potential that we can work with them for the programs. This institute right now has a lab office space ready, and it's about 12,000 square feet. And we have the access to the BO3 lab over there in the university. We also have the access to the animal center. So we're looking for more space when they are building the basically new lab over there. So what we are doing right now is we try to build a core facility, the lab and the office over there that include a laboratory core, statistical and data manager core, as well as those clinical core, training core, and others. And we wish those core will support the different programs or projects that basically involve our people in China. And I will get back to those programs, some of those ongoing programs later, especially related to HIV research. This is actually the picture that is on the construction, actually, that the building that in Guangzhou. Hopefully that we can get more space over there. And here, this is actually calling the lab of the ITM. You can see that it's basically with standard equipment over there as what we have here. This is the lab. This is actually the lab bench, and this is a hood, culture hood, similar as we have, and the incubator. And you can see the microscope and central features over there. Those dark rooms with computerized the geosystem, and those PCR systems, including the new PCR 7500 real-time PCR. So we have those institutes is well equipped, and this is actually the office and the conference room. The infrastructure is ready in this case, and we welcome people from our university to contact us and to hopefully that this will help you as well. So we are basically developing those agreement and discussions with the China CDC and to build a multi-phase collaborations. Phase one is really to build the joint vaccine infectious disease center over there. That basically is in mid of our strength here, as well as what the China basically wants to do. So to basically allow us to assess a larger resource over there. This actually is a new. This is a picture of the new campus where we are going to move on. The center could be in one of those buildings where I don't know. China CDC is very special and very powerful in China, and it could be considered as both CDC here as somehow function of NIH here. So both epidemic origin, those field, as well as some of the power research and the fundings. And China CDC is also special. They have 3,400 branches. Over China, and that at different level, they call provincial CDC, city CDC, county CDC, or district CDC. So the very different levels. So, but the network basically allow the district or county CDC report to the disease directly to China CDC Beijing. So it's very powerful, and we with the institutional collaboration agreement with China CDC, we will have the access to entire those network of China CDCs. So the second half, and I will talk more about the scientific programs. The phase one program, as I mentioned, is really a focus on the infectious disease, and the goal is really for vaccine and the therapy. So we specifically want to define some special mechanisms that vaccine-induced protection against some of those major infections, as well as some of the natural immune control of infections by a system biology approach. And we hope to speed up the development of novel vaccines for some of those diseases that are basically difficult to make vaccine, like HIV or TB, and others potential preventable disease. So this is really the picture, a view of the overall view of the program. We say vaccine and infectious disease program. Basically, there are three major programs under this larger programs. The first one is look at the common mechanisms of infection control that basically we and some others identified. Some of those people naturally can control infections. Including those HIV, TBs, and I will come back to this more later. But it's those people who naturally control without any anti-infection therapy. So it's sort of those endogenous vaccines. And for HIV, for TB, those is very important because we don't, as many of you know, that we don't really have a vaccine yet, even we work so hard for HIV. So I will come back to this later. The second program is really look at the mechanism of vaccine protection. What we propose to do is really look at some of common features of some of those successful vaccines, and to see any common or important features that can help us to design the vaccines for other very difficult to prevent infection like HIV and TB. So this program is kind of external and compared to this one, endogenous vaccine design. Okay. But this program will include many different programs. One is very pretty new system vaccinology. Basically, use a system biology approach to look at this vaccine. And we also include, hopefully, with this program, we can develop something, the new vaccine, and then in that case, we will contact those vaccine trying. And one of those is really the larger program from ANH funding program, HVT, and its HIV vaccine network may do the work in China. So what we hope from those programs that we can get something that will allow us to design the vaccine. But you have to test those in the animal model. That's why we have the third program here, and to test those. And from those system biology studies, as you will expect, there will be a lot of those bioinformatics data, genomics, genetics, and protein array stuff. So we group nicely two groups basically. One is a group from Steve Self, who is more the statistical data manager, and then another group is Sage, who's actually just come off from Rosetta. It's more specific for genomic database analysis. So these two will form the data analysis core for us. So I will focus right now more on the program that I basically do. It's actually infection controller. The overall goal is really to identify some of those lead people, those people, special people that can control HIV, TB, HBV, okay, and other infectious diseases. There are a lot of people. Again, I will come to this later. We propose that is because based on what our expertise in the last 10 years that in research here, but also in some of the new technologies that we developed that allow us to identify those infection controller that I'm going to show you later a little more. So with those, hopefully with this we can get a reasonable, basically larger cohort. That's why we need the international collaborations. Then we can allow us to do the mechanism studies. Okay, that as I mentioned, we will use a system biology approach, genetics or genomics or protein array stuff to do that, and allow us to really systematically evaluate the mechanisms for this important phenomenon. So the evidence for control of those infections is actually latent infections, or part of those latent infections that are extremely latent infections, because some of the latent infections do get the disease. Okay? So latent infection is actually common. It's not rare, it's actually common. Many infections, including some of those most serious diseases like the TB, like HIV that I will describe later, and hepatitis and others. Okay? And they can infect latently for many years or even lifetime. Okay? For example, about 1/3 of those people in the world actually, or even more in China, is about 44% of Chinese population are estimated to be latently infected with TB, basically. And among those latent infected people, only 10% of people basically in the lifetime somehow, sometime point, they will show up disease. 90% of those people are unknown. You don't really know where they are. Okay? And they can activate the disease and then transmit the disease to anybody. And say in TB case, that typically people don't really recognize or think about it that they are TB infected until get really sick. And in that case, typically, the transmission happened already to other people. Yeah. So, however, the current situation is really this detection of the latent infection has been very difficult, and there's no effective assay. Specifically, problem is really because this requires very high sensitive but very specific assay. Okay, otherwise you will not be able to detect it, or either contaminated or either not sensitive enough. And definitely, there's no treatment for acute latent infection. These two areas are actually major funding area in the Gates Foundation as well, globally, basically. So I would like now to talk a little more about specifically about what we have done for the HIV control studies. Typically, HIV infection result in very different outcome. Okay, many of those will progress to disease very quickly in 5 years. That's what we call these people rapid progress. And some will progress to disease slower in 5 or 10 years. And some may not progress disease for up to 10 years. And that's what people initially call long-term non-progress. And in recent years, there were studies show there are the very few, actually it's 1% of the HIV infected people can actually control the infection with undetectable viral load over there for 20 years or longer. So that's something actually very important for the vaccine. And this is actually a picture from our studies and show these people, as shown in the dark blue. This is people, the viral load, in this case HIV DNA per million cells in the blood. The dark is those people without treatment. These people typically have a high viral load and will progress to disease. And some people in green, they have a relatively low viral load and they will progress to disease slower. Okay, and as I mentioned earlier, this is actually what the people call controller. As you can see here, these people were typically identified by clinical. They were identified after 10 years or 20 years infection. Hey, people felt, oh, these people did not progress to disease, and they come back to look at these people. Okay. And this is our result, actually, when we looked at the viral load, which is the major marker for disease progression. And you can see these people have very low viral load compared to any group over here, even compared to these people treated in the blue. Okay? However, what's missing, you can see here, because these people was identified by clinical 10 years or 20 years later, there was no information about whatever happened here. But this is important. The early phase of infection is actually important for the vaccine development, for therapy. And so how these people control in this early period is missing. Yeah. So that's the major gap. And our lab work basically try to solve these issues. And I will show you later, we actually have an assay that allow us to detect the patient in the early infections. So basically, this is summarized here that basically our group has been initially shown both in human as well as in animal model that I will show both data a little bit. There are those very low infected people when you use very sensitive assay, and these people basically survive for long, very long. In animal, that I can show you actually lifelong survival. Okay. So we did that is because we developed an assay and that allow us to do it. Here it's basically showing that I will come back to this later with detail. So because the assay is really we identified that. Okay, so this is something. So I will just give you some idea about the assay. This is a comparison with our new assay with the real time that are very commonly used in here in the many lab. Okay. There will people say if you improve the real-time PCR, you might be able to detect very low viral load. Some people even say it's 1 copy. But I can tell you, we tested that. We found out is this is not an assay that can detect latent infections. And one of the major reasons is really because of the sensitivity and the specificity. So we have developed this assay, as what you can show here, is much more sensitive than the real time. And this is real testing the patient samples, especially for those samples with very low viral load. Okay? So many of those samples, we dilute that and probably has no viral load, no HIV over there. So that's why not all positive, not 100% positive over there. Yeah. But our assay shows significantly more sensitivity than the real time. We also compare this assay with probably one of the people believe is the most sensitive PCR is limited dilution nested PCR, which basically is a double PCR. People will consider this is the assay that can detect one copy, and it's probably reached the limit of detection. But when we compare this assay with our assay, two of those limited dilution assays, you can clearly see to testing the patient sample, you see we did a lot, over 1,000. Actually, we have more data. A larger comparison, okay, then our assay is very significant, better than nested PCRs. So this is basically, and I don't have time to really present more about this assay and basically this assay is more sensitive but also very specific because we include the sequence procedure in the assay. So allow us to confirm any positive test, which is very important. As what probably many people know, more sensitive assay typically has a problem with the contaminations. So we have a very well control of this. So this slide basically shows the data that we have from the patients, and this is what the data that from 4 of those people that we identified from early. Somehow this doesn't work well. Early infections, okay, and the viral load was very low, down to 1 copy, around 1 copy, 1 million, which is comparable to others that identified the controller that are 10, 20 years later. Okay, we actually have data show one of those people who actually now enter into the 10 years marker, which will define as a long-term non-progressive or controller, as people will define here. So we actually use our assay, we are able to identify this early. And another significant finding is really we identify another group that actually had even low viral load, and the antibody was negative, which is typically the way the diagnosis is HIV. So by common diagnosis, this might be uninfected. But with our assay that we actually identify the HIV DNA over there. Okay, and so these together offer us a very unique opportunity to look at the early events of the infections. And what is interesting, actually we published the data, but then we extended these studies later, is we actually reproduce this phenomenon in animal model. Monkey was infected with the SIV. What we identify is, those people which were initially identified as uninfected. Okay, from 100 of those monkeys that on some other studies. Okay, and we basically use our assay. We were able to identify the SIV DNA all over the lifetime. And what is significant is this monkey can survive for 15 years until sacrificing. This is very remarkable because typically SIV infected monkey will die in 1 year or 2 years. Okay, they never survive over 2 years. Okay. And in this case, people with this load, basically in monkey model, actually they survive for a lifetime. So that could be a lifetime controller. So why those HIV infections is so important to focus is because it's really the relevant to the vaccine. As what I said, HIV vaccine has been very difficult to make. In general, vaccine works well to actually not really prevent infection for viral infections. Basically, it's really slow down the viral load and cure to clean the virus. Okay? So So indeed, and HIV vaccine effort has been basically focused on this, on the hypothesis. Actually, is proved in animal model. Basically, just make a vaccine that can keep a virus in check, at this very lower levels, that these people will not progress through the disease or will not transmit their virus to other peoples. However, the difference between the SIV monkey model and the human HIV infections prevent the directly those implications to that. This is actually evidence in recent vaccine trial. One that very big news is fail of the vaccine from Merck. The vaccine actually works very well in the monkey, but fail in the human. So understanding how to control HIV, you need a human model. And this HIV controller is really the most relevant and human model for HIV control and protection studies. So our unique technologies as well as identifying the controller provide us a very unique opportunity to study the early events, which is important for the vaccine. And more likely, we believe this is going to be multi-mechanism. So we believe the study will involve many different studies: virologists, genetics, immunologists, clinicals. So hopefully, this will provide us new information for vaccine and therapy development. As what I said, we expect this is going to be multiple factor. If the could be virus factor, if the virus is attenuated or defective in other infections that are approved. So then these people and the virus from these people could be a good candidate or a template for making those attenuated vaccine. Definitely the immune response, especially innate immunity, might be important. So that's why you need those genomics and the protein array to do that. That's why we needed the interdisciplinary collaborations. And one that is really critical for this study is really you need a large cohort. That's why we need the international collaboration. And I can tell you is we have worked with Africa and others for pretty long, but unfortunately we never scale up to the scale that we allow us to identify enough people to do that. Basically, you only get the high-risk people would screen for those controller, about less than 200, and then only get the 20 or whatever people that have those control. But in China, that we actually right now we within 1 year we actually getting almost 500. So we did further on study the mechanisms. I'm not going to talk very much. I think let's go back to this. So we first we studied the genetic the host factor. In this case, we look at some of those genotype that might be associated with the disease slow disease progressions. In this case, as I show here, some of the factor that was proved previously by other lab as well as our lab, like CCR5, Delta 32, which is basically CCR5 is the receptor for HIV to enter into human body. That's established infections. When the Delta 32 basically is that there are 32 base pair nucleotide acid missing, deletion over there, that basically result in defect CCR5. So people with those heterozygotes either protect or infections or either slow disease progressions. So we did identify some of those, and there are other peoples who actually have different HL typing that might be more likely, progress to disease slow. But I have to say that none of those factors exclusively slow down or control infections. Many of those people with those the genotype progress to disease. So that's why the mechanism is far away to be completed. Basically, there's fundamentally no lack of those understanding of the controller. Similarly, for viral factor, we do have some data shows that that the virus, in some of those cases, say for example, in this case, we don't really see any change of the virus for starting period, it's many years. And we could not, even use our sensitive assay, we could not detect the virus in the plasma. This all data basically together will indicate the virus over there might be somehow, either could not replicate or basically because of the defect or whatever. Okay. There are other cases that we didn't see the significant sequence change, but we do detect the virus very little. Okay, by our assay in the plasma, which indicated there were very, very small amount of virus produced over there. Okay, so might be host cell, might be viral, both. Okay. But there are some cases clearly we see the virus change over there, and this change we actually identify later on. Actually is associated with immune repression, immune response over there. So that basically means immune response also play a role to control this viral. So basically, it's what I said earlier. Control of those infections are pretty common. Okay, and there are something that we will look for. We hopefully look for that will, that can contribute to control HIV infections, TB infection, or TB infection. Or hopefully, we can bring that together. This is our program basically. So I will use next few minutes just tell you. The new program that we just began to develop with Dr. Lee Hardwell, who's the president and for the Hutchinson Cancer Research Center. I don't intend to talk detail about this program. Just instead, I will just provide borrow some of those slides from him to provide the idea how he wants to do. And the overall goal of this program. It's really this program, what they call is a partnership for personalized medicine, and through a new diagnosis test strategy. The overall goal is really using this assay, that's a new assay basically he's going to develop, to help physicians to identify patient early, or even help physicians to make decisions to how to treat that, or when to stop that, and for those. Okay, so that may be essentially will reduce the cost. Okay, that's why his final goal, ultimate goal, is really to reduce the health cost. The idea basically is because, as well all we know, healthcare costs are increasing dramatically, actually worldwide. It's not only one United States, but specifically United States, you can see that the healthcare cost increase dramatically in the GPT ratio. You can see from 10% to 16% right now. It's estimated by 2005. Many countries, including the United States, will spend 20% of the GDP on health cost if we don't make any change, remain current pace. The problem that one of those problems is really a lot for example, for cancer, is really the cost for treat the patient, especially those patients later, is very expensive, and compared to those people in the early, the expense is much expensive. Okay, a lot more money. Okay. However, on other case, the survival of those patients who identify early could be very high, 90% or, but later typically is very low. Okay. So cost is high, and later treat cancer, and survival is low. So this actually is what Dr. Lee Hardwell said. This is actually provided is the opportunity, okay, for how we can improve the molecular diagnosis to basically solve these issues. So he believes that we can do it right now. We can do that using the better diagnosis to hopefully identify even early some of the people before the disease. So basically identify the risk of disease, and also diagnose those people with early stage cancer. Then you can treat early, the survival better and less cost. Okay? And also can diagnose early, but also help to physician to make decisions with a different test with the biomarker. Basically, that's what he's going to do. Okay? Very different biomarker using genomics, protein array, those different biomarker to help that. Okay? So that's why he thinks this can be done. Why? It's because the technology advanced. Okay? Especially in the last decade, sequencing, array, or those new technologies are significantly improved. Okay? Because of that, the biomarker data, information increasing dramatically. The problem is there's really no people really try to get those data together, those biomarkers and together, and to evaluate those biomarkers and to further develop those for clinical usage with the diagnosis testing. Okay? Nobody really put all those together. There are studies, individual genes or individual markers, whoever says he's better, okay? Company or lab. Nobody put all those together. So this is this is really that Dr. Lee Holloway wants to do, and requires larger population studies. That's why he found out in China there's a very opportunity. He actually say, identify in some other case like colorectal cancer. If we are going to do here to get enough patients, we probably need 5 years, but we can do that in 1 year in China because the population is much bigger. So that basically, and I'm not going to talk about the details what Dr. Lee Holloway is going to do, but he does develop a new model, what he calls the partnership for personal medicine model of diagnosis development. And he's interested into the cancer and as well as the infection. And one of the key for this is really bring those clinicians. Try to find out bring the clinicians, okay, together with the scientist who knows how to do those biomarker, discover biomarker and discover the assay, together with those healthcare provider, okay, and to form some of the those biomarkers that are needed for diagnosis, and then develop the assay with the industry, and then apply this to clinical studies. Okay, we developed a very easy assay like array, protein array assay. What I'm saying there is testing array. It's not that fancy machine. It's basically just like ELISA, whatever possible. Okay? But with the new technology he has. So hopefully they introduce those in the patient's practice. This is basically what he wants to do. That's what I say. I'm not in the position to talk this program in details, but I trust it. And also, I think I'm almost at the time, and so I will. I would like to acknowledge as many as well people involved, but it's simply impossible. There's so many people involved, and it's more than 100 people or whatever from different organizations. So I listed here, UW, Hutch, all the China stuff. So I will stop here, and if I have time, then I will be happy to take questions. Thank you. Thank you for coming.
Questions for Dr. Lee?
So I really like your correlates of immunity studies and the elite control studies. So Bruce Walker on the East Coast studies elite controllers, and they find that like one of the things they do is that they make a response against just a few like very specific HIV proteins, whereas progressors make all this non-specific stuff. Do you see that, and is it explained by the HLA association?
Yeah, this is actually a great question. One of the goals of Bruce Walker's program that he basically make this international program, large controller studies. That's what I say. It's basically those identified 20 years or whatever. But he has a large population. So that one of the fundamentals is really that we don't really know. It's really what's the mechanism, how many different mechanisms will contribute. What you mentioned, I believe in some cases might be the case. he also had the study shows some of those what I showed a real gene, HLA real type, or he actually has some data shows acquired immunity. But his group also shows that there are many cases nothing with the immune response. And he basically said that fundamentally there's no conclusive conclusion over there that the acquired immunity will be important. It's more likely innate immunity. But what is the innate immunity? Nobody really knows. The study that he's doing definitely is fantastic. It's great, okay? And it's, you can't really say anything more. But as what I said is the major early infection information is basically they're missing because they cannot identify the early control.
And I guess I have one follow-up question. Are there any elite controllers who convert to looking like they have sterilizing immunity? The virus goes away completely?
From immunology studies, I think for different infections, people were saying that some of those innate immunity may contribute to either viral infections or bacterial infections. Okay. And also, there are studies show innate immunity not acting alone. They might actually act together with some acquired immunity or enhance acquired immunity. So those together somehow they can work. But the situation here is for controller, actually is really for HIV. Okay. It's difficult. We don't really know what our traditional idea that acquired immunity, which is typically we believe is required for vaccine, right? So basically, effective vaccine that you look for is really the vaccine can induce antibody, induce T-cell immune response, then they can prevent infection, right? But in HIV case, this doesn't work. We have made many different vaccines that produce pretty well, antibody response, pretty well T-cell response, but doesn't work. It works in monkey, but doesn't work in human. That's why we at this point, we don't have any vaccine yet. So it's something maybe beyond what we can understand, acquired immunity. That's why in last few years, innate immunity has been one of the hot spots for HIV.
So I have a question about sort of the population genetics, and I think that from a different perspective, this is an opportunity to look at the role of genetic differences between Asian populations and where you're planning to do all this research over in China with Chinese populations and compare them to studies in European and Caucasian populations where much of the previous research is done. Are there plans to do that? That sort of thing?
But we actually had been initially tried to do here in last 12 years with collaboration with Julie McGrath and Larry Corey, all those people, as well Connie Collins, who are leading many different clinical trials in Africa as well. What the reality is we have never been able to get so many study subjects for almost 12 years. As what I said, we only get 15 around those controllers, which is not enough. For those genetic study, population study, you should look for 100, 200, whatever those. Well, we are now doing with China, phase 1 is already 500. And then we expecting scale up in the next 5 years to 25,000. So we believe that it will offer an opportunity to really get this, those scientific, difficult study done with those larger populations.
Any other questions? Well, let's thank Dr. Zhu again.
Well, thank you.